I am going to ask you all to raise your hands now if you think Obamacare has failed. Who thinks Obamacare has failed? Okay, and now raise your hands if you think Obamacare is so far a success. Okay, we're going to do this again at the end and see how many of you have changed. And then I will declare a winner. Very good. We're short on time, so let's get right into it. I believe, Donald, you were going to start us off here. 3 minutes on the clock.
The first couple of comments I'd like to make about Obamacare is really about our healthcare system here in the U.S. We have a crisis. We continue to have a crisis. We've had a crisis for several decades here. That's not a surprise. Our healthcare costs are almost $3 trillion. We have consumes almost 18% of our GDP, and it's been relentlessly increasing over the last several decades. Despite this, we have 79 million people, or almost a quarter of the US population, that is either uninsured or underinsured. And we're spending a lot of money per capita on healthcare here. Lots of disparity in healthcare and healthcare coverage related to access, the affordability of insurance, and actually the ability to get insurance. We have a healthcare system that really is it's an insurance system that's really prepaid healthcare, with changing a bit, but really has not been self-pay or high deductibles. We have an economic system that I call supply and command. For you economists, that's kind of a takeoff on supply and demand. That is, I as a physician kind of tell you what you need. There's an asymmetry of knowledge between you and me, and I'm also supplying the service or related to the person who's supplying that service. That really doesn't give you good market economics. Despite all this, we have a really sophisticated system when it comes to scientific discovery and clinical innovation. There's just very little innovation in the actual delivery system. So, kind of what I've learned over the last couple of decades in the healthcare system here in the US is that, and I've been in the management of healthcare, is that the payment system does not really create a management system in healthcare. It doesn't really help to manage the system. So what did the ACA do? There were initially, past 4 years ago, it created affordable and available insurance. It got rid of pre-existing conditions. It got rid of individual rating. It created an individual mandate, which the Supreme Court upheld. And that says that you have to have insurance, and if you don't, I don't have to pay for you. It created substantial subsidies for low and moderate income people, and it created exchanges to sell the insurance. It improved Medicaid. It made Medicaid more understandable and uniform. This really helped access and is really good for the healthcare system. Actually, it's really good for the population, not necessarily for the healthcare system. It took baby steps in terms of actually providing the kind of incentives we need to manage care. It did things like medical homes, ACOs, changed the reimbursement system, especially for Medicare, to create more accountability for care and not just more of the fee-for-service. So in conclusion, it did a really good job at creating access. It did a really bad job at helping to change fundamentally how we deliver care, but it did create the access to the system. Now the challenge is going to be how we deal with that.
Great, thank you, Donald. That was 4 minutes, so we'll give you 4 minutes too, John.
I'm older than he is.
So, we won't really know, will we? Because the maximum leader has made us all do it. So we won't know the road not taken because we all have to go down the road taken, which will just be another chink in our humanity and our individualism and our chance to be creative, unique individuals, which breaks my heart because I think the biggest problem with healthcare in the United States is not how outrageously expensive it is. That's a big problem. That's the second biggest problem. The first biggest, though, is that for all of that money, 25% of the life's work of every steam fitter in this country, it's not really an expression of our humanity. You can't trick it out and pick up dates. You can't say, screw you, you're fired, I'm out, I don't want this bad deal. You have 62 million Americans today who are covered who don't want a primary care doctor. 84% of those covered for a Medicare wellness visit opt out. They are conscientious objectors, even though the money has already been taken by force over the course of their careers. So the idea of saying, of mandating that this thing that so many people don't like get bought seems, well, it seems like a really bad dream. Even the people who sort of trimmed around the edges and said, fine, I'll buy disaster insurance. I'll pay a little bit of money so that if my tractor rolls over on me, I won't lose my farm. It's like 1.2 million of those people, and they were told, no, you may not now keep that insurance. You must discontinue it. Those don't feel like big successes, big expressions of the greatness of the human condition or the American experience to me. Between 1989 and 1997, healthcare became a smaller and smaller and smaller piece of the American market basket. It got cheaper relative to the gross domestic product for every one of those years. And the way that happened was that these kooky little profit-maximizing weenies called HMOs went around building these things called networks, saying, if you don't give me this rate, I'm going to get all my members of my little HMO to go to another guy over here, and scared these guys into collaborating. Then you had PPMs come and try to create the ability to upstream the HMOs. And then you had hospitals go and acquire, remember this? Hospitals go and acquire doctors to try to be their own PPMs to upstream the PPMs. You have all these players creating different packages. You had discount HMO products where if you agreed not to have experimental procedures, most of which, by the way, ruin the end of your life, or some of which do, and some of which are great, and you should choose, you could get an even cheaper product. And that experience continued all the way through the mid-90s, late 90s, when we started to have an internet boom, and people started to realize that they had that disease that needed the experimental procedure that they didn't want when they were paying for the premiums. And Barbara Walters got the special with the guy from Humana, and the government started in a wealthy economy to start to limit the ability of these weenie health plans to do product management, to shop, to steer volume, to be in a marketplace. And so when it became illegal for health plans to be in a marketplace, you saw health plans start to make profit another way by merging and getting administrative savings and building large, pointless sort of organ donors of corporate waste that they are today. I don't think that had to be the way that ended, and I don't think locking those ridiculous institutions into our society by federal mandate is going to make healthcare any cheaper or is going to make healthcare any more humane.
All right. Weenie health plans. I like that.
HMOs.
Great.
I mean, everyone doesn't like them anyway, so we might as well call it.
All right. Donald, rebuttal.
So a couple of points I want to talk about. The one is personal choice and individual mandate. The problem we have in healthcare is that if you make a choice to not wear a helmet when you're riding a motorcycle and you have an accident and you're taken to the emergency room and then you're in my ICU for 3 months on a ventilator, that's a very expensive care. You've made the choice to not wear a helmet, but I've had to pay for that. So it's important that we understand that what personal choice means. If you want to opt out of the system or opt out of not getting care, that doesn't mean that it's up to me to provide that care for you. But as a society, we certainly wouldn't let a trauma patient not get care. We're going to provide that care for that patient. In fact, there are mandates out there. If you're going to be a hospital, you're going to provide that kind of care. So, I do have some problems with the individual mandate or personal choice, but I have more of a problem when it becomes my problem, when I have not been able to have anything to say about that. The second thing is kind of this term HMO. So, back when I was a resident, it was a little bit later than mid-last century, here in Boston, we had one of the great, original managed care plans here called Harvard Community Health Plan. And as a resident, I used to take care of their patients at Children's Hospital and at Mass General. And they really created integrated healthcare delivery systems. I mean, the physicians were together, a lot of the institutions were together. There were 3 or 4 of these plans that were the great hope of the US healthcare system because they were able to produce some kind of outcome for some kind of cost and manage costs. So we had a real inflation in healthcare, and then the answer came, well, we're going to have more HMOs. But those HMOs were really not the health maintenance organizations of the 60s and 70s. Those really were, I used to refer to them as 1-800-SAY-NO. You know, they really detracted from the care of the patients because it made it very difficult for me to give that patient that care. And I would not want a system that went back to that rationed the care that I thought was best, or that rationed the care that actually society or the system could actually demonstrate was best. So on those 2 points, Jonathan, I really have to disagree with you.
Fabulous. Choice, right? So I rode here, sorry, on a bike with no helmet, hair flowing in the wind, and it was fabulous. And I feel bad, because if I go to the NICU, you will be paying. I guess not, Athena will be paying. But also, I did not eat a lot of corn-fed steak, and also I I try to exercise a fair amount, and also I don't watch a lot of TV, and I don't smoke a lot of drugs, and I don't drink a lot. So anyway, maybe we could all just be human and bounce around and live in the earth and not be right. I mean, the idea that now it's legit to say what you just said about a fellow American not wearing a helmet or not doing this, because now we're suddenly wired in a way that your humanity, you expressing something as native as riding your bike, is now an offense to another person. That, to me, is a decay in social fabric and in joy that is vastly more painful than the expense of the one poor bastard who ends up in the ICU. You know, I mean, how many have there been? I mean, really, and by the way, with the cost of the current system that has now been locked in by law to be that outrageously expensive, we could run ICUs from here to kingdom come. There is no way we could generate enough motorcycle accidents to come anywhere close to the overpayment that we've got. In terms of rationing, we ration. We ration. We get the Samsung instead of the Apple. We get the, Louis Boston instead of the Filene's, or the other way around. We ration all the time. What we don't like is someone else doing our rationing for us by force. You just said you didn't like 1-800-GO-SCREW-YOURSELF or whatever from the health plan. Well, now you've got a committee in Washington of our betters literally defining the definition of what can be said yes and no to. What could be more 1-800, you're not in charge than that? Of course there's going to be rationing. And there are aspects that it's still allowed under. Luckily, Obama kept the $5,000 deductible that the Bush administration put in. They kept a lot of things that made it possible for employers to continue to fight, to shop, to create. The point of rationing is really the issue, right? The point of rationing far away feels disempowering. The point of rationing being you yourself deciding what you want feels like shopping, feels like being alive and well in a nation of commerce.
He's more entertaining than I am, that's for sure.
It was the bike ride, I tell you.
Let me ask the first question. Let me direct it to you, Donald. Stepping back a little bit, one of the main criticisms of the American healthcare system before was that it was a muddle of subsidies, of regulations, and of the marketplace. And now, post-Obamacare, we have a system that is a muddle of subsidies, regulations, and the marketplace. Have we just traded one dysfunctional system for another?
The fundamental problem is that we have a dysfunctional healthcare, actually a fundamentally dysfunctional sick care system. I don't even want to call it a healthcare system. And Obamacare didn't do much to change that. The ACA didn't really do anything to change that. It just gave a way for people to have access into the system that is dysfunctional. So I don't think we can, so we certainly have traded, we're putting a lot more potential patients in that system because now they have access to care that they didn't have before. They have access to a system that doesn't work, that's not integrated. The whole healthcare delivery system, I mean, I would like to say we could sit down in a room, 500 of us, that was tried, in 1992, I wasn't one of them, to come up with a new healthcare system. It didn't work. I don't think we're ever going to see the revolution in healthcare delivery that we need to see. It's going to be some kind of evolution. And we have to hope that we don't completely break the bank on the way there, that we can actually understand how to deliver all this innovation in clinical medicine that we're getting at now. The personalized medicine, we heard some of that, kind of understanding the basis of disease, and that we're, a lot of drugs, as an example, maybe only have a 60 or 70% effectiveness. That's because diabetes is not diabetes. When I was a resident, we learned about cancer as where it occurred. It was a breast cancer, it was a liver cancer. Now that's not the situation anymore. We're really getting at the molecular understanding of that cancer and the really selective therapy for that. This is proteomics, this is genomics, this is really understanding this. How can we get that knowledge into the system? We need to change fundamentally the healthcare system. Obamacare didn't do that. So we still have a long way to go in that respect.
Okay. Jonathan, another separate question for you. I mentioned some numbers in my opening remarks, and the ones I'm referring to are the Centers for Medicare and Medicaid Services projecting a growth rate that is below historical averages in terms of healthcare spending. Yesterday, the CDC came out saying that the number of uninsured in America has dropped considerably since last year. And some states are showing only very, very moderate rises in premiums. These seem like very good things that could be associated with Obamacare.
That's why I sort of mentioned the other periods of time when we've seen even lower growth of healthcare costs than we're experiencing now. We are at the same time as having, Obamacare is a manifestation of many things that were going on. We were feeling very poor and a little bit scared, right? So we have a flat economy, very little biodiversity increasing in the number of businesses. The economic growth is bad. Unemployment, although recently improved a little, still pretty shitty. And so that's a good environment for employers to be tough and say, hey, I'm not going to let the cost of health insurance go up. And that's going to drive that. So the AQC contract here in Massachusetts, with Blue Cross Blue Shield has shown actually one of the biggest reductions from the most expensive in the whole country down, but a down 8% is a pretty big reduction. No one else is down. You're showing slower increase. So it's not that Obamacare and the generic feeling of this is too much and it's out of control won't stem. It's just whether the idea of forcing everybody to one committee's way of doing it all is better than the road not taken, which we'd still have the weak economy, we'd still have stronger employers, we'd still have the $5,000 deductible that is now kicking back off. Remember, we saw consumer-directed health plans rise. Obama got elected. Nobody wanted to be the last employer to stick the big deductible to their employees right before Ed McMahon was going to come with a cardboard check and give you health care, right? And so it froze, dropped. Then we waited for Obamacare to settle in. Now we realize, oh, nope, it's still back on us again, just with a lot more feathers on it. And so now you're seeing those deductibles and that consumer-directed product tick back up again, which does allow for the things I'm describing. It's just throwing this layer of mandate on top. So I don't deny that healthcare is getting, the rise in cost is getting stemmed. It's going to get better and better and better. We are going to really, really reduce the cost, or at least, I think we're actually going to reduce the cost of healthcare over the next 5 or 10 years because the economy isn't going to get much better and all of this pressure is going to be there. And you got all this fixed cost in these hospitals that are about to go bankrupt. And as they actually do go bankrupt and redeploy into skilled nursing or condo or whatever, that fixed cost gets released and their ability to monopoly price gets released, and suddenly you have, you actually take money out of what Don calls the sick care portion of the healthcare system. Now we may consume it right back up in all kinds of things that we desperately need in mental health and visiting nurse and all kinds of other things, but the sick care stuff is definitely going to get cheaper, and it would happen a lot faster and be a lot more humane, in a more humane way if it wasn't for Obamacare. But even Obamacare cannot stop that inevitable from happening.
Okay. Let's open it up to the audience. If you have a question, please raise your hand. We'll bring over a microphone. No, yeah, right here. And please, no polemics. If you're a politician, let us know and we'll escort you out.
I'm Dr. Jessica Shanahan. I work for the VA Boston. I just wanted to make 2 comments supporting Jonathan Bush. So my first comment.
We got one.
I voted yes before, so I'm not
shit.
a switchover. My first comment is associated with David Goldhill's book, something about catastrophic care, how American healthcare killed my father. And one of the examples in that book was in Soviet Russia, they had restricted the amount of choice in toilet paper to one brand. And when his grandmother, I think it was, came over to the United States and tried toilet paper here, our very worst brand here exceeded the quality of their one brand there. So that's one example, I think, of how choice affects the quality overall. And then the second point I wanted to make was in support of something Jonathan had said earlier, and I'm completely ripping off your book, where you talk about how access to care does not eliminate risk. Because if you have further access to care, you can also increase the amount of testing that you have and interventions that you have, and there may be complications associated with that. And because the quality might not be what we would hope as it would be in a private sector, that's not something to dismiss.
Okay, let me respond to that point about access to care not eliminating risk.
Absolutely. I mean, that's what I've been saying. The problem is with the healthcare delivery system, not the access to it. I mean, if we have a poorly functioning healthcare delivery system, no matter who's coming into it, they're going to be at the same risk. So Obamacare, I don't think it's called the Affordable Care Act. I think it meant affordable insurance premiums, not affordable healthcare. So, and you would think that the insurance premium is related to the cost of healthcare. I'm not always sure. It's related to what we're willing to pay for healthcare, or what an employer is willing to pay for healthcare. But the fundamental issue is the healthcare delivery system. But we have to have some system to make sure that people have access to a healthcare system.
The question is, though, I think to your point, which gets you better access, which gets you more affordable access? Some sort of price fixer from on high that defines what's best, or the ability to, you have many buyers, many sellers, and freedom to move about the cabin. And time again, the latter generates price reductions. I mean, let's be clear. The correct market price today in the United States for a hospital bed is about 45% below the actual fully loaded cost of having a hospital bed. Why? Because we have 45% more than we need, right? But the government isn't going to mandate a price that's a definite money loser through Medicare, right? So the capacity is going to be held in place, floated there, drowning us. You used the Russian example. I used to drive an ambulance and got a chance to ride in an ambulance in Russia in the 80s, and they sent out doctors on the ambulance in chronic cases. Like, you're so backwards, you can just have the medic, whatever. And they were adorable, broken little ambulances. But all their chronic cases, they treated in place. They did the EKG, they stabilized the drugs, they stabilized the oxygen, they stabilized the sugars, whatever it was, and they said goodbye, and they drove away. In the United States, it's illegal for an ambulance to treat the patient in place. And so we drive these poor chronic, 8% of our patients are driving 35% of our spend right now on chronic diseases, and half of it is picking these poor people up, perfectly able to treat them right there, but the only way you're allowed to get paid to submit your claim is you schlep them into the hospital, make them wait 4 hours, spend 24 hours getting treated like shit so you can go back and get the oxygen and sugar and whatever it is you needed in the first place that the paramedic could have given you. So that's an example of an idea that in an open environment where everyone's allowed to play, that would have been done a long time ago. Now there's a group, community paramedicine is trying to lobby for permission to do this with their betters, and ARC is doing a demonstration grant. I mean, duh, right?
Let me push you on the price fixer on high that decides what's best. Not using Russia as an example, but maybe using England, where I live, as an example. The NHS does a pretty good job of this. They have much lower costs than America, similar outcomes. What's wrong with that system?
Well, I like you very much, and you're the moderator, and I don't want to get in trouble with you.
I'm deciding who wins this. Remember?
Yeah. No, I mean, one of the things we didn't come up in the debate is this notion of being half pregnant with the marketplace, right? So we've got everybody in the United States and maybe in the world is in their own way profit maximizers. There's no such thing as a non-profit hospital. They're the most profit-mongering, just like everybody else. Nothing wrong with that, but nothing different about that. The difference is here, the demand curve is basically rendered illegal. You can't actually shop and get a cheaper price because that's been taken out of the equation. But the rest of it is a marketplace. So you could either go all the way over, which a lot of sort of older doctors on athenahealth, screw it, take it. Let's run it all on Medicare. Let's just have a single payer because I'm so tired of not being able to do the right thing, right? And then you can sort of do an on-high, top-down, it's the public school system. Everyone's going to get educated. Some people might like it. There might be committee lobbying to change the teacher, whatever, but it's there. And we could go all the way to there and sort of completely dehumanize it, and it would be more efficient than the half-pregnant thing. I'm just saying if we went all the way the other way, or just a few steps the other way, we would have a level of humanity that the NHS does not have. It's very bureaucratic, sorry, but it's hell there to be part of it, and it doesn't change very quickly. And it's not an expression of humanity the way so many things in this country are that make people like it here and come here and officiate at really cool events here.
Thank you, Jonathan. This idea of the marketplace, I mean, this was one of the points of Obamacare, creating these exchanges, which Obama does refer to as marketplaces. But, I mean, how much are they really markets when there's no price transparency, when the patients who are meant to be these intelligent consumers don't really know how to actually shop for health insurance, and in many states, it's too small to have an adequate market.
Yeah, and I think that actually, you point up a good problem, an important problem. One is there's an essential market basket of services that each of the insurers through the marketplace have to provide. And there's some, so to help folks understand what they're getting for what price. I'm a pretty sophisticated healthcare buyer, but I've never been able to look at the health insurance that I get and really understand what's covered. So I think that that's a huge problem, and I'm not even sure the insurers know what's covered or what's not covered. It's a claim is submitted and it gets adjudicated and it's either denied or paid, and sometimes it comes up to some kind of medical decision within the insurance company. But I don't think that's not a problem of the ACA. I'm going to just want to give you an example of Medicare Advantage, which actually, we heard a little bit about that from the folks at Humana this morning, actually has done pretty well because the payer does get a PMPM, per member per month payment. And then that payer can offer services, at least at the Medicare fee-for-service level, but more. And I think the number is right now, 30% of the Medicare beneficiaries are covered by Medicare Advantage. So that kind of, even though the premium, if you will, is set and mandated, I think we've gotten really good, I'm not going to call it innovation, we've gotten better coverage. Of course, in the early days, it was because these plans did a very good job of kind of understanding who was healthy. I mean, we're going to go find the seniors who were working out at the health club, and we're going to give them, we're going to enroll them for Medicare Advantage. I think those days are over, but I think that's a good example of how a fixed premium that these plans get, and then these insurance companies can really manage the way services are delivered. They have to do it much better than they currently are and offer more services, and people will go and buy that.
Okay, let's take another question from the audience. Right over here. Wait, where are you from? Are you? Yeah, you're not from his organization, are you? No. Okay, you're allowed.
We are hiring though, so before you ask your question. No pressure there. Going back over everything I said. Yeah.
He's buying lunch, by the way.
Concern is that individuals are making the right decisions for the public, and we're seeing that right now in Massachusetts with measles and with whooping cough. Isn't healthcare just a modern tragedy of the commons that we can't rely on individuals to actually they're going to make the right decision for themselves, but not for the society?
This is a great, and it actually fits with the earlier question that you asked to Don, that one of the, so aside from many buyers and many sellers creating innovation and creating price pressure, it also creates an opportunity for a thing called product management, which was another thing that was made largely illegal by not just Obamacare, but other sort of the CPT codes. That the product in healthcare is 6,700 CPT codes that are federally mandated, right, licensed by the AMA, and they are only allowed to be sold for the reason of 10,400 going to 140,000 ICD codes, right? That is clearly not the perfect environment for a consumer to shop in, right? So one of the things that could be made possible, and is much more possible under Medicare Advantage, as you pointed out, thank God they weren't able to kill that, which they tried to do, and replace it with ACO, which is a joke, is create the opportunity for somebody who is an expert to be the shopper, the insurance broker, right, the stockbroker. And the doctor is increasingly finding herself in the role of saying, yes, you need a mammogram, but you don't need it as much as if you came from this background, and given your deductible, I need to tell you that you are actually only 0.25% likely to find something, and if that happened, you'd be only 50% likely to need surgery, whatever the numbers are. Suddenly, the doctor in these contracts that are Medicare Advantage contracts or the AQC contracts are actually finding themselves in a position to be expert shoppers, and when there are shoppers, those who are selling to a shopper start to product manage. So we already have clients that are saying, we will do a hip replacement, all in, 23 hours, 2 years of rehab, all the repairs you need for 2 years for $42,000, and it includes a round trip on JetBlue. That's a never seen before thing in independent medical groups. We've seen Cleveland Clinic actually hire 8 salespeople and go around the country selling all-you-can-eat, fully loaded cardiovascular surgery, including round-trip airfare. They closed Lowe's stores and Walmart. So there is the beginning of product management sufficient that a consumer wouldn't be overwhelmed and might do the right thing. But when it's so completely abstruse, opaque, I think you end up with people not knowing what to do and what not to do because the product hasn't been managed to where a consumer can shop for it. Meanwhile, the day before the new Samsung comes out, there's a line around the block, people who know that it's 20% cheaper here than there, right? And they're ready, they've figured it out, they've grokked the difference between, how many megahertz that screen has and this, and they're shopping for it.
Okay, with that, I think we're going to move on to closing statements. And Donald, we're going to start with you. 3 minutes. 2 minutes. 2 minutes.
Okay. So, certainly a crisis in healthcare. Roger talked about the increasing cost of healthcare expenditures. We're spending way too much. I think we spend twice as much per capita in this country than most other countries for understandable results. But we have lots of people who are underinsured and uninsured, lots of disparity in healthcare, lots of asymmetry in knowledge between the providers and the patients. Maybe not you as patients, because there's some pretty sophisticated patients here, but lots of asymmetry in knowledge, and we need to get rid of that asymmetry and let folks be better shoppers. Our payment systems have not helped to manage the healthcare system. A lot of discussion around the ACA, which has been a good thing because people need to talk about healthcare or sick care. I mean, lots of conversation about population health. What does that mean? We heard examples this morning where we're going to take the health insurance premium and start paying for the health of communities in things that aren't related to sick care. I mean, I'm not sure that employers necessarily want to do that for employees that may not be with them down the road. It's interesting to see how that's going to work out. I think everyone will agree that that people have to have access to health care. There may be debate of what that healthcare system looks like, but people have to have access to health care. It can't We have I would say, a social contract in this country that people have a right to get health care. We've certainly done it in many ways. People can walk into an emergency room, have to get covered. They can walk into if they get hospitalized and can't afford it, they get treated if they receive federal funds. So people have a right. We need to organize this in a way. We need to get the folks the health insurance coverage they need, and ACA has done a very good job in doing that. There's lots to be done. That's the beginning of helping to increase the cost of health care, because now we're going to have a lot more people in the system, and now we have to work on the healthcare delivery system to not just bend the curve, but to actually reduce the curve, to make it go down.
Great. Jonathan?
We do have a crisis of the common. That's a perfect capture of what we have. We care too much to let people go, let them die, let them not get what we know they need. And so we need a way of filling that fundamental breakdown in the marketplace that we refuse to let happen. Right? And that's good. That makes us an empathetic, welcoming, warm place. You know, I believe in safety nets. I think most of us believe in some form of it. But now the question is, how do we get out of it? What actually creates the most utils of social good in terms of, actual fixes of medical ailment, and while simultaneously preserving as much humanity as possible, as much personal power as possible? It is my belief that the way you do that is you invite many, many purveyors into the bazaar. You let many people have a crack at bringing wellness, bringing illness to an end. And you move the point of rationing from where it is today as close as possible to the family and the soul in play. I don't think we can go all the way to the consumer today quite yet, but I don't think we should go further away from the health plan to the government. I think we should go from the health plan to the doctor, to the medical group. And when the medical group shops, the product will improve. And once it improves, it will be something that the consumer could ultimately shop for. That is an audacious and beautiful vision that I get excited about every day. And I'm not daunted by Obamacare, but it didn't help much.
Very good. All right. Now we decide who has won and who will be paying for lunch. Let's have a show of hands again. Who thinks Obamacare has failed? Okay. Who thinks it has not failed?
Any converts?
Very
Just
good.
one convert.
Yeah, were there any? Did anyone actually change their mind? No, shocking.
One convert, two converts.
Very good, very good. Jonathan, you are paying for lunch.